We'll get started in about 1 minute. We'll just let a few stragglers join. Okay, we can go ahead and get started. Welcome everyone to tonight's webinar, Punishing Ourselves When Incarceration and Health Collide. My name is Mark Robinson. I'm an internal medicine physician in Houston, Texas, and a board member of Doctors for Change. For those of you who are just meeting Doctors for Change for the first time, we're a Houston-based nonprofit seeking to improve the health of all Houstonians and Texans through education, research, and advocacy. Our guiding principle has always been improving the health for all people. And so often, those who are currently incarcerated or who have previously been incarcerated are removed from conversations about what makes a healthy society. We've been partnering with Texas Jail Project, an organization that fights day and night for the rights of those who have been impacted by the carceral system in Texas. Over the next months and years, we hope to grow this relationship using our expertise as healthcare providers, educators, and researchers to lessen the health impact of jails and prisons on the lives of Texans and Houstonians. Tonight's webinar is called Punishing Ourselves, because what happens to a person after they are arrested in many ways impacts us. Studies show that as more people are jailed in a county, the death rate for the public increases. The decisions we make as a society to incarcerate people does not just negatively impact them, but us as well. If we ignore the collision of health and incarceration, we're not doing our due diligence as health advocates. But as important as it is to discuss the public health impact of incarceration, we should not forget the direct impacts incarceration has on those whose society has chosen to lock away. People and patients who receive death penalties even before they have a trial. We were starkly reminded of this today with the report that Billy Davis, a 35-year-old man who was recently in the group transferred from the Harris County Jail to the LaSalle Correctional Facility in Louisiana, a transfer that Texas Jail Project fought tooth and nail against, was found dead in a punishment cell. 35-year-old healthy men should not die suddenly. So let's take a few moments to honor his memory in silence, and then we'll move on with the presentation. We're hoping tonight is just the beginning of a conversation, and you can certainly be part of that for those of you who are on Zoom or on Facebook Live. For tonight, please place any questions you may have in the comment in the chat box. Also, please visit the Doctors for Change and Texas Jail Project websites and learn more and sign up for our mailing lists to find other ways to get involved. So without further ado, I'm going to introduce our first speaker. So Dr. Eric Reinhardt is a political anthropologist and psychoanalyst and a resident physician in the Physician Scientist Training Program at Northwestern University's Department of Psychiatry and Behavioral Sciences. He is the lead health and justice systems researcher at the Data and Evidence for Justice Reform program in the research group of the World Bank. His published work has appeared in medical and legal journals, including, but not limited to, such small journals as the New England Journal of Science, The Lancet, the Proceedings of National Academy of Sciences, Health Affairs, Journal of Legal Studies, and in various media venues such as the New York Times, The Atlantic, Slate, The Nation, Boston Review, Jacobin, and USA Today. His areas of research and teaching include anthropology of law, inequality and public health, psychoanalysis, ethnography and aesthetic politics, and medicine, policing, and the logics of apartheid. During the COVID-19 pandemic, he has focused on immediately applied policy-oriented research on the politics of public health and the carceral community epidemiology. That is, the way in which health and welfare of incarcerated people is always intertwined with that of broader communities. Most of his work examines the relationship between systemic prejudice in healthcare and legal systems, and uses the confinement and punishment in the US and internationally, and large-scale decarceration policies as essential for public health and safety, pandemic preparedness, and biosecurity. I've been incredibly amazed by his work at a distance, so I was selfishly very excited that we were able to invite him here. So thank you very much, Dr. Reinhardt.
Thank you, Mark. I'm an anthropologist by training and a physician. I spent 10 years doing ethnographic work in the south and west sides of Chicago in intensely dispossessed, primarily Black neighborhoods. And I had never done empirical work or policy-oriented work, empirical quantitative work, or policy-oriented work really until the pandemic. And there was a reason that kind of my whole research orientation and my relationship to politics as an actor, not to political ideas, but what I might be able to do shifted with the pandemic. Up to that point, I had really been interested in the way in which people write themselves. They refuse to be written by histories of violence. They refuse to be written by narratives of gangs, of gun violence, of poverty, of tangles of pathology, as they're famously described, these Black neighborhoods in Chicago, et cetera. What does it mean to write oneself in that kind of a discursive context in the US? But when the pandemic began, I put all that to the side, in that this really seemed like an emergency. But an emergency I think I had failed to recognize prior, or failed to act upon in the way that I think we have an ethical responsibility to act upon prior to that moment. I don't think in many ways that what changed with the pandemic is as great as what we imagine. It brought to light and allows us to trace violences that the carceral system and our policing systems perpetrate all the time, not just during pandemics. COVID allows us to show how, and this is what my research is largely focused on, show how infections that are acquired and multiplied in carceral contexts inevitably go back out into communities and inflict massive suffering that is not directly attributable in most people's eyes to the carceral system, but in fact it is traceable back to the carceral system. COVID illustrates that dynamic in a way that we can measure because we suddenly have data sources. They're horrifically inadequate, but they're far better than the data sources we had to trace the public health impacts of carceral systems prior to COVID. But the fact is, with all of these transmissions of COVID from somebody who goes into a jail during processing is exposed, then perhaps they're released 2 or 3 days later, they don't even know they're positive, they go back to their families, they spread COVID within their neighborhoods unbeknownst to them, and a lot of people end up dying from this. We don't know how many thousands, but without question, thousands of people, tens of thousands of people have died because of jail-acquired and jails distributed kind of infections. This same thing has been happening for decades with respect to other forms of harm that are more difficult to trace because we don't have data sources for them. I think we're meeting now, and I guess it's 2022, I'm told, and now there's an imagination, a popular imagination that's false, but nonetheless is quite dominant. I would say dominant is certainly in media. The pandemic in the US is coming to a close. That the emergency that we needed to respond to 2 years ago has dissipated and now things can go back to normal. In fact, that's the desire for a large proportion of people, primarily in privileged positions, but also in other positions. The normal to which we would be returning within the carceral system that we have returned to already, unfortunately, is a normal of massive violence that is multiplied by a carceral system that does not protect public safety, but in fact always inflicts harm that disseminates back out into communities. So although my own research for the last 2 years, and there's no reason you should be familiar with it, but it's been focused on trying to trace how COVID is multiplied by these contexts and spread back out into communities and accounts for a massive proportion of COVID disease and death that has racked the entirety of this country. That is simply an illustration of these broader dynamics that pertain to diabetes, to cardiovascular disease, to trauma and psychiatric sequelae that come from this. And this affects, diabetes, heart disease, these things, these chronic diseases affect people who are exposed to incarceration, but they also affect their families and their neighbors and their communities. And we talk a lot about hospital capacity right now, healthcare system capacity. Is it being overwhelmed? Healthcare system capacity in the US, a huge proportion of it is occupied dealing with the fallout of our incredibly punitive, irrationally punitive and violent criminal legal system. And this is true all the time. This is generally only garnered attention with respect to infectious diseases. So this has also been true internationally. Part of why I came to this work is since I met Paul Farmer in 2008, we had been teaching courses on this same dynamic that I've been talking about with respect to COVID, with respect to TB in international context, specifically in Russia and Peru and other places in South America, where TB is multiplied within prison context. MDR-TB is generated, which is multi-drug resistant TB. And this causes massive epidemics that affect whole societies. So when the pandemic began, I realized this was already going to be a massive influence with respect to pandemic control within the US. But I think the challenge before us now is to begin to think about these things beyond infectious diseases alone, and certainly beyond COVID alone. COVID is not done, and it is still greatly affecting these carceral contexts. But I think as a community of physicians, as a community of people who are interested in public health and carceral change, we have to begin to use the levers of public health and to break down the barriers between popular conceptions of public safety and public health and show that these are, in fact, one. And if we do not produce effective public health systems, we do not produce effective public safety systems. And if we're producing so-called public safety systems that undermine public health, we are doing no service to even the wealthy and privileged of America, let alone dispossessed communities that are at the sharp end of the stick with our carceral system. So, I mean, this is like very broad terms that I've kind of spoken about here, but I hope in the Q&A we can speak about this and kind of specific questions that people might have or in more detail. But I'll stop for the moment and let others speak, and then hopefully we'll come back and have discussion.
Well, thank you very much, Dr. Reinhardt. I have many questions for you for the Q&A, so hopefully we'll get there soon. Next, we're going to have Dr. Allison Crawford speak. So Dr. Allison Crawford is a prior obstetrical nurse and current T32 Provost Early Career Postdoctoral Fellow with the School of Nursing at the University of Texas in Austin. Her research is focused on addressing structural racism and the social, economic, and political barriers in childbearing populations influenced by incarceration. Most recently, she is working on developing a mobile health application to address sexual violence and reproductive health disparities in female populations on community supervision. Over the years, Dr. Crawford has actively worked to build valuable partnerships through collaborations with a variety of nonprofit organizations, such as Texas Jail Project, to inform policy on behalf of individuals with histories of arrest. In 2019, she participated in researching and writing testimonies on behalf of Texas House Bill 1651. In addition, in 2021, she testified on behalf of HB 1308 to improve prenatal care for pregnant and parenting individuals in Texas County jails. Moreover, Dr. Crawford has been awarded the Social Justice Scholar Award and the Sigma Theta Tau Nurse Leader Award for her nursing leadership, and has been appointed as a board member for Pay It Forward, a unique nonprofit that assists individuals with substance use disorder and histories of arrest. So please join me in welcoming Dr. Allison Crawford.
Thank you, Dr. Robinson, for that great introduction. I'm so privileged to be here with you all today. And just like what Dr. Robinson had said, so prior to research, I was an obstetrical nurse. And what really brought me to go into research was witnessing the inequities of the populations that I served that had histories of arrest. And so I'm going to talk a little bit more about that as I go through this presentation, and also share some of the stories of the people that I work with on a day-to-day basis that are pregnant and parenting within Texas and that have histories of arrest. So women's incarceration, this is pretty alarming. I saw this as an obstetrical nurse, but I really didn't know the data behind it until I started within my journey within research. But women's incarceration within the United States has increased exponentially over the past 40 years. Most of this population is on what's called community supervision, which is parole, probation, and oftentimes court-mandated medication assistance therapy for substance use disorder. Predominantly, this population is arrested for low-lying offenses, such as petty theft. Most of them are primary caregivers to young children under the age of 10. If you look at the incarceration rate compared to the global incarceration rate, so we represent 5% of the global female population, however, 30% of the world's incarcerated female population. When we look at Texas, and this was just mind-blowing to me when I saw this for the first time, if you compare the incarceration rate of women in Texas compared to other states within the United States and other authoritarian countries and countries within NATO, we incarcerate women 10 times greater the amount. Within this population, which is really unique compared to other populations, we see 2/3 of them rearrested. We call that recidivism within the first 6 months. And data shows this is because we don't really have gender-specific care and addresses gender-specific needs, predominantly of individuals who identify as women and individuals who identify as mothers and caregivers. Another thing that was really mind-boggling for me to wrap my head around is that a lot of these low-level offenses cost around $10,000 or so to bond out of jail. So for those of you that are not familiar with county jail, a lot of these women are put in what's called county jail, which is the holding facility, before they are actually sentenced. And so a lot of them are not convicted of any crime at the time. A lot of times in county jail, and this is the big issue here whenever we talk about health-related issues, they lack policies and mandates and resources and research that sort of bridge initiatives, and health equity and initiatives compared to other facilities outside the county jail. So a lot of times they are here in this holding facility. It could take, usually we like to say, a couple of weeks or months, but a lot of times, especially with COVID, it's taken over a year or more than that to get out. And so during that time, they're without health care. During that time, they get their parental rights involuntarily taken away. During that time, they not only get their health-related resources like Medicaid taken away, but also their children's resources are taken away during that time as well. And so if you think about the median bond amount for them just to bond out so they could find representation, legal representation, and actually care for their children while they await trial, a lot of times they cannot do that because their annual income is roughly around $9,000 in this population. So it's a 1 year's worth of annual income when they get arrested for things that they might not even be convicted of. So when I started going into my research, there was a gap in research around the populations here, specifically in Texas. A lot of them did not include childbearing communities here in Texas. And looking at the data, the national data, we know that Texas incarcerates women at a much greater rate than other regions of the world. So I decided to focus my efforts on Texas communities, particularly those in the South Central Texas region. And my data paralleled a lot of what the national data showed. So predominantly, a lot of these women, I focused on the Latina ethnicity because that was also addressing a gap. We didn't really have a lot of data on Latinas, but predominantly they were single. They roughly had about 4 to 5 children. A lot of them had at most a middle school education. We could talk a little bit more about that in a little bit, but that was related to a trauma that they had prior to arrest, which led them to arrest initially. The median annual income was roughly around $9,000 for them annually, and they were predominantly arrested for low-lying offenses. All of them went to county jail. None of them went to federal prison, and most of them had community supervision for roughly 2 to 5 years. So these are some of the stories that I wanted to share with you, because a lot of times, especially in healthcare, we are often, judgmental. Sometimes a lot of our care are punitive in nature. I've witnessed it as an obstetrical nurse numerous times, not giving, evidence-based care to people that have histories of arrest, such as not allowing them to hold their babies or breastfeed or have adequate pain medication during the labor process. So let me just tell a little bit of their story as I go through these quotes. And so this one really hit home for me, and it was echoed by numerous of my participants within my sample. So this described their abuse. This one participant said, the physical abuse, the emotional abuse, everything. I just felt obligated to sleep with these guys, because if not, I didn't know how I was going to survive out there. Basically, I just did whatever they wanted me to do. And that was a theme of my research. A lot of people who identify as women that get involved with arrest, a lot of them come from extreme violence and abuse prior to arrest. After arrest, the political, social, and economic barriers that come with felony disenfranchisement and just the nature of community supervision often makes them in a more vulnerable state, where they not only were abused by romantic partners that often exploited them for financial gains, such as forcing them to go into sex work, but also the institutions of power that were associated with the institutions of arrest, such as community supervision, medication assistance therapy. There was a lot of stories of court-appointed attorneys, bondsmen, and people like that who sexually coerced these women to do things for them. And so the violence just was perpetuated after arrest, which really perpetuated their morbidity and mortality around reproductive and sexual health issues. And I didn't warn y'all, so I'm sorry that this is sort of a trigger warning. So these slides are sort of hard to share, so I apologize. So this one describes their violence. A lot of them had extreme instances of violence. This described how a romantic partner was physically and sexually abusive to this one participant. And this was not an outlier. This was very, very common within the sample. But this person described how her boyfriend at the time told her, he said, "Come here, let's make this even better in blood." He sat me on the chair, duct taped to my legs, my arms, and my mouth about 10 times. He started shooting. I remember him taking a deep breath. He just started hitting me with the gun. He literally messed up my face. He threw me in the closet for 2 days. This sexual and physical violence went on for about 10 days. And this story was outrageous. I couldn't share it all with you because of time. But, you know, and I've seen this as a nurse and a clinician, and this is one of the reasons why I went into this area of research, is because as a nurse, you know, I often, just for me, I had to have that human aspect with my patients. I had to talk to them and get to know them outside of the hospital setting, and get to know them outside of being the patient, right? And I volunteered a lot in the community, and I saw a lot of myself in the people that I served, regardless of their incarceration status. And I saw them, you know, stigmatized and treated differently. And once you get to know them, you can understand, you know, some of the things that have happened in their life. But I see them getting misjudged a lot. And as clinicians, you know, you see on paper a lot of their physical and medical health history. But what you have to remember is that these people come from extreme trauma. And when they access care, you know, our job is not to stigmatize or be judgmental, because a lot of times that deters them from care and actually perpetuates more violence. And often I get a lot of, I had a lot of stories where people intentionally, right, either got arrested because they didn't know where to access healthcare, and healthcare in jail is often, that's a whole other thing that we could discuss later. But we really perpetuate disparities when we are judgmental against people who are trying to access healthcare services when they have certain disparities with this. This is another really outrageous story. So this is a story that describes the abuse of power that's perpetuated after arrest. So this story echoed a lot of other people's narratives. This one in particular was about a court-appointed attorney who coerced a participant to repeatedly have sex with him after she was arrested. So she said, "When I stopped answering his or her attorney's calls, at the time I was out on bond, he went off my bond," meaning he stopped representing her. So she had a warrant. She said, I stayed in jail for 6 months. And so if you could think about what that means, if you have a child, a young child, right? Possibly, Child Protective Services involvement, possibly involuntarily garnishing of parental rights for this person. She said he went to the jail and said, you want to try this again, or you want to go to prison? So who wants to sit in jail? So I got out. Then when the forced sexual assault kept on happening, I ended up getting pregnant. Then he made me go get an abortion. This narrative describes the jail care. And so I hear this all the time. And I was on a call a couple of weeks ago with other clinicians who asked me, they said, well, Allison, don't people get care in jails? Isn't that a positive, for going to jail? They could get health care. And I had to describe that, no, the health care that they get, and I never want to undermine the attempts of other services and institutions that they give. I mean, yes, there is some type of care in jail. However, the narratives that I've shared with you before, jail in itself perpetuates violence, PTSD, and other issues for this population that we could avoid if they just stay out of jail, correct? And it also makes them in a more vulnerable state and puts more barriers. So when they get out of jail, a lot of violence and inequities perpetuate. Also, a lot of the care in jail is dangerous, it's late, and a lot of it is misinformed or not the standard of care that you and I think would be the standard of care. When I first started with this research, I just assumed, I was very naive, that I come from the ivory tower of academia and nursing school. I thought that everybody got the standard of care regardless of incarceration status, but that's not the case. And that's why I've done a lot of advocacy and collaborating with the Texas Jail Project, because I've been alarmed at how much they don't get standard care in jails. So this person describes the jail care that she got. And so she said she was pregnant at the time. And she said, I was bleeding. I kept telling them I'm having a miscarriage. I need to go to the hospital. They, the guards, were like, shut up, sit back down. The participant said, I'm bleeding, help. She spent an hour banging on the window. They would not talk to me. I was in a lot of pain. I had to literally beg one of the guards to come get me, and then they took me back to the hospital. I had lost my baby. And this happens time and time again. And unfortunately, Texas, we have, and Chris, you could correct me. I want to say we have roughly over 250 jails, county jails in Texas. I could be wrong. But we have a lot of rural county jails, and a lot of jails don't have clinicians that are trained in labor and delivery and the signs of labor. And so this happens so many times. It's unbelievable. And so it's just outrageous when I started to learn a lot about the experiences of these individuals that are parenting and pregnant and in jail. So implications for policy, and I'm just going to go through the main ones just for time. So, the biggest thing is policies that reflect humanity. And if we trace back, the history of incarceration in the carceral state, it really is, punitive mindsets around people at the intersection of gender, sexuality, color. So really changing the narrative, partnering with people who have lived experiences, changing our language around these issues, dismantling patriarchal systems that contribute to sexual violence, learning that we often think as society that somebody needs to be punished or go to jail and they'll be better when they come out. And all that really this data is showing is that we put them in a more vulnerable state. And a lot of times, oftentimes, it's perpetuating sexual coercion and violence. Another really neat thing was technology. So this was during COVID. And so a lot of their counseling and case management services were streamlined through technology, and people who worked or that were caregivers, predominantly people that I interviewed that were mothers, they said that this really worked for them. So using technology to bridge services and streamline services for them to, have a somewhat normal life after arrest. Implications for health education and practice, so trauma-informed care. And so we've all sort of learned today, I hope that, the antecedent or the precursor to arrest is often trauma, okay? And then, afterwards, a lot of their health disparities is also trauma related. So trauma-informed care partnering with different, community partners. A lot of times we're siloed in our attempts. So I really appreciate this conference right now where we could have a platform to speak about these issues. Also, doing things that are patient-centered regardless of incarceration status. So this population, they talked about not having the opportunity to have weaning plans to taper off their substances, having inclusive sexual health, the opportunity to bond and breastfeed with their babies. And implications for research. So of course, focusing on intersectionality in Texas communities, we have a lack of data here specific to Texas, more focus on the LGBTQA star community, more focus on county jails. I can't stress that enough. People say that, oh, we don't want to fund or we don't want to research county jails because, there's a high turnover and yada, yada, yada. But that really is where a lot of our disparities are that trickle down into the community that really affect public health. And that is all. So I'll give it back to you, Dr. Robinson. Thank you.
Thank you very much, Dr. Crawford. That was wonderful. And I have many questions written down for you as well. So we're going to be up really late tonight. Okay, so our next speaker is Jorge Reinhardt. Jorge is the National Criminal Justice Director at Latino Justice. His role is to coordinate national policy aimed at eliminating the criminal legal policing and carceral apparatus as it currently exists, and to do that by identifying Latinx individuals who have been negatively impacted by that apparatus and support them. He draws on his experience of spending 27 years of his adult life in Texas cages, being on parole until 2051 for robbery committed in 1991. Previously, he was a senior policy analyst at the Prison Policy Initiative and a senior organizer at the Center for Community Change. He was the 2020 Poet in Residence at the Civil Rights Corps and the 2021 Writer in Residence for the Texas After Violence Project. So I'm so happy and so pleased to have Jorge join us. Jorge, go ahead.
Yeah, hi, good evening. It's a bit intimidating, to be honest with you, right? Listening to some of the learned and journals that the previous two speakers have been in, and some of what they bring to the table. I like to say that I'm an expert very little, that I'm an expert in my own experience, right? And I think that's the value that I bring tonight, that I bring to this panel, that I bring to this discussion, is my willingness and ability to observe and record some of the things that I've gone through in my 27 years that I lived in a Texas cage. So I want to speak to a couple of things on that, but I also want to talk about, I think one of the things that we've understood, or that we are pretty well going to agree on tonight, is the what, right? And the what is the fact that people who are incarcerated, people who spend time in cages, I mean, we're not talking about any other countries, we're talking about the United States, and probably specifically Texas, have health problems beyond the norm, that whatever health problems they had before they go into that system are surely exacerbated by their experience walking through that system. And then, of course, we as a society have to endure that. We have to pay for that. We have to find some way to remedy that. But I think that the why, and I would hope that we were able to come to some sort of agreement, is because to kind of generally push back against something that was recommended by Dr. Crawford, is that policies that reflect humanity. I think we put people in the cage to be punished. It's a contradiction in terms to believe that anyone can go through that experience and that they're ever going to be seen as a human being, someone worthy of spending time and money and effort and expertise and bringing people who have knowledge to that experience and say, we're going to treat you like a human being, if the initial purpose, if the express purpose of that experience is to punish. And of course, one of the ways that we do that is by dehumanizing individuals. A little bit of my experience, I think, might be a bit, I should have been applied this. I was lucky in that I went to prison first when I was 20. I was I'm going to say 1977, and I was released finally in 2008, right? But of course, I had 4.5 years of freedom in between that. I went down 3 different times. I've always been pretty healthy most of my life. I took care of myself. I jumped rope when I was in prison. I ate all the peanut butter and crackers that I could, let's put it that way, right? I had 2 direct profound experience with the medical system in TDCJ, which is the Texas Department of Criminal Justice. One was early on in my first year when I was incarcerated. I had my head, I was looking down the run, which is what it's called, the outside of a tier of cells. And they were closing the door and they hammered it on my head and they almost severed my ear. I backed off and I sat down on the toilet. They slammed the door shut, and the guy who lived in the cell with me called the guard, who finally came down, and my ear was hanging down, blood was gushing. They took me to what passed for the unit infirmary, and I had, at the time, they had people who had been convicted working as inmate doctors. And he literally stapled my ear together. And I mean, with a stapler, he used a stapler to staple my ear together, and I still have the scars. It eventually healed, a little bit crooked, you know, I'm not too worse for the wear. But yeah, and then in 2007, I was granted parole in late 2007 to be released in 2008. And I was playing handball on a handball court, and someone came behind me and I hit him, and I ended up tearing my tricep. And my tricep immediately collapsed down here, and my entire arm immediately, my right arm immediately went black and blue, and I couldn't move it, and I didn't know what I had done to myself. And I went to the infirmary, and they said, "There's nothing, it's bruised." They sent me back to my cell, and of course, I was much more than bruised. And they finally took me to John Seeley in Galveston, which is one of the hospitals that's associated. I don't know if it is now, and I know it's Texas Medical Center in John Seeley, but I'm not sure which ones are actually have direct associations, or with the Texas Department of Criminal Justice. And what they told me there was that they could, in fact, operate on it and reattach it and fix it to whatever way it could be fixed, but that it would have direct and negative implications of my parole. I'd been granted parole. And of course, I didn't want that. So I just said, don't worry about it. And I just went back into sort of personal healing on my own, and I'm lucky. Every now and then I have a lot of pain. My arm doesn't work the way it should, but that's okay. I mean, I'm living, right? Which is more than I can say for a lot of individuals who are incarcerated. A couple of the things I think, I talked a little bit about the what and the why, and some of it is the how. How are we dehumanized? How is it that a system, how is it that individuals who are part of their ethical training has to do with beneficence and maleficence, right? And the concepts that are associated there, right? Beneficence do good, maleficence do no harm. How is it with individuals who part of their ethical training and part of their expertise and part of their professional mandate is, of course, to do no harm, to do good, can get caught up or get sucked into a system like the Texas Department of Criminal Justice or the county jails, right? Where the actual medical providers, because what happened to me was not an outlier. It was not something that, oh my God, Jorge, it just happened to you because of who you are. You see examples. I am not a doctor, so I couldn't sit here and tell you that the medical care that was given to someone was substandard, right? But you see individuals who go into the infirmaries, you see individuals who are obviously dying, you see individuals who are coughing up blood, and then you never see them again. Now, is that part of the how there is because the system is set up in such a way that the individual guards are allowed and encouraged, in fact, to make immediate medical assessments of individuals, and they're the gatekeepers. They decide whether or not you are actually going to be allowed to walk down that hallway, whether you're going to be allowed to meet your what they call a lay-in to go to the infirmary, right? And then once you get in there, whether or not if you have some sort of attitude toward the admitting guard or whatever, whether or not to send you back to your cell. So you have to go through that gateway. Dr. Crawford a minute ago talked a little bit about that, right? But I think some of that also is that in order to work in a prison, prisons dehumanize everyone who goes into a prison. And not just myself, not just the guards, not just the wardens, but also the staff of the staff members, the doctors, the nurses, psychiatrists, psychologists. Anyone who walks into that atmosphere is going to be dehumanized to a certain extent. And what happens in order to exist in an atmosphere like that, to not be called, to not be dismissed if you're a professional, to not be called, to not be accused or be told that you're participating in hug-a-thug therapy or something, right? To not be diminished, to not have yourself diminished. You end up adopting a posture of dismissiveness. There used to be a disciplinary case in the Texas Department of Criminal Justice called malingering. And they would, in fact, write you a disciplinary case right? If you told a guard that you wanted to go to the infirmary and the guard decided that you did not exhibit any symptoms of whatever it was you said you had, whether it was a cold, whether it was a flu, whether it was whatever, and they would write you up for malingering and they would send you back to your cell or to your living area, and then you would have punishment on top of whatever symptoms, whatever disease, whatever sickness you had. And I can't tell you how many times that I've gone to the infirmary for minor stuff, for cold, for flus or whatever, right? And literally, and you see this in court cases, you see this in Reese versus Stell, you see this in a lot of the legal cases that are referenced when it comes to the way that prisons in Texas were transformed and the plantation prisons across the South, that what they would do at many times, they would give you 2 Tylenol and send you back to your cell. That's what they would do. And of course, they're able to do that because of the societal attitude that says that these individuals deserve whatever it is that befalls them, that they are there to be punished. And the way to do that is you have to dehumanize them. And at that point, everybody else becomes complicit in the system, right? I can't tell you the gratitude or the humility that I have being on this panel with individuals who have the credentials and the compassion that has been demonstrated by the individuals who preceded me in this presentation. And I would pray that after going to a prison and working in a prison, actually going day by day with individuals and them themselves being dehumanized by the atmosphere and by the guards and by the wardens and by the pressures of the job and by having to see some of the individuals who would go in there and were malingering and were trying to get out of work and were trying to do whatever it was for personal gain. We're trying to stack up medicine or whatever for their own purposes, that they would be able to surpass that, right? To surmount those pressures. One last thing I think that is perhaps not taken into account when it comes to the why and the how. The 13th Amendment of the US Constitution outlawed slavery, except there's an exception there, except when you've been convicted of a crime. I think that's somewhat dismissed. Is it chattel slavery? No. Does the state own your body and your work and your daily lives? Yes. And they tell you that over and over and over again. And many people think, oh, well, it's the private prisons that are actually profiting off the backs of the incarcerated individuals. No, private prisons are a very, very small slice of the individuals who are incarcerated in this country. In Texas, which has maybe 145, 146,000 people in its prisons, the guards do 3 things. They pass out mail, they turn keys, and they count. Every other job in the prison system is done by someone who's been convicted of a crime. In order to keep that system running, they have to keep people doing mopping, sweeping, folding clothes, making food, cleaning the kitchens, driving the tractors, driving the trucks. Everything else is done by someone who's been convicted of a crime. And we don't get vacation, we don't get sick time, we don't get any of those things. And in order to keep a position, in order to keep a job, you have to show up to work. And if you are, a lot of times, if you do have a medical condition and you've been given a prescription by a doctor that says, you know what, you can't go outside, you can't work in direct sunlight, you can't stand up over this, whatever, right? If the position that the prison system has assigned you to do and wants you to do and orders you to do it, you have a choice at that point, because a doctor doesn't accompany you down the hallways or out to the back gate when they tell you that you have to go pick up a grubbing hoe in order to go out and work in the fields. The nurse doesn't accompany you, right? When you go into the kitchen or when you go into the laundry room or when you're pulling out clothes for 8, 9, 10, 12 hours out of the dryers. The nurse isn't there with you. And if the guard is telling you, you have to do this, your alternative is do it or get a disciplinary case, which has a direct impact on your parole, on your good time, on your living conditions, on all of that. And so you make a choice. Do I endanger my health? Do I continue doing what it is that they're telling me to do, right? Or do I say, no, I'm not going to do it because I have a prescription here from a doctor that has told me not to do it. In order to keep the system running, the guards assume that they have the ability to assess your medical condition and will daily, hourly, all the time, every day, assign you to work and make you do work and make you do things that are totally going to contraindicate whatever it is that the doctor and a very likely a caring and concerned and competent medical staff has told you not to do. So again, that is what I bring to this table, and I'll let this go on because I know we're probably a little over time.
That was wonderful. Now, I know there was some talk that you had a poem that you wanted to read. Do you want to do that now or do you want to do it later? I don't want to put you on the spot.
I can do that now because we may not come back. Dr. Reinhardt started this talking about COVID. Yeah, so this is directly about COVID in Texas Department of Criminal Justice. It's called Death in the Name of Abbott. Squeaky clean and sanctified is not a concept associated with sinks and toilets occupied by groups. 2 squatting over here, 3 spitting into that rust-encrusted bowl over there. The crush amplified by a rush of musky, smelling like last week freaks fighting for the last shower head and passing around a piece of lye soap, greasy with fur razored off a dozen faces. Distance is unattainable. When penance demands not personal examination or a transformation of systems, but a set number of seconds stacked upon minutes, scratched on concrete walls, and humans lying on racks after racks in cement-lined packing crates. And so it's no surprise that death in the name of Abbott is but a sneeze away. Sniffles sneaking from cell to cell, coughs echoing down the quiet runs. Bodies toe-tagged and dragged down the hallways, explained with a dismissive wag of the administrative tongue as to why they declined to release the barely breathing into the less desperate, lonely confines of love and life outside the wire, because that could be unpalatable for the politically inclined. So let them die. Just let them all die.
Thank you so much for sharing that. That was wonderful. And I think I speak for everyone here that you may feel like our credentials mean something, but compared to what you bring to the table, they don't mean much at all. So thank you very much. Our final speaker is Thea Sebastian. Thea is the Director of Policy for Civil Rights Corps. In this role, she oversees a range of initiatives that include policy changes both to end systemic criminal legal injustice and build a new non-carceral paradigm for community safety. This work includes legislative engagement at the local, state, and federal levels, the development of policy resources, proposals, and model legislation, and policies support to movement organizations. Prior to joining the Civil Rights Corps, Thea worked primarily on social and educational policy, particularly issues relating to economic mobility, educational equity, and social enterprise. Immediately before joining the Civil Rights Corps, she served as Associate General Counsel for Mayor Muriel Bowser. She also has experience teaching, including 2 years as a special educator in South Bronx and providing policy analysis advice on political campaigns. Graduate of Harvard College, Oxford University, and Harvard Law School. I've heard of those. Thea currently serves as one of 30 members of the Harvard University Board of Overseers. In her free time, she is passionate about creative writing, yoga, protecting voting rights, Indian food, rom-coms, and never being forced to learn home repairs. Thea, thank you so much for joining us tonight.
Thank you so much for that, Mark. And just to start, Jorge, just want to say that if you felt at all intimidated, I feel 10 times more intimidated having to go after you. So thank you so much for your remarks. I think that the nice part of my role on this panel is that as the policy person who is tapped here, what I can do is talk to you a little bit about the world we can actually build on the other side of all this that can hopefully move us away from all of the problems that we're talking about here tonight. And so to that end, I want to start off with just a few overarching messages about how I think about policy when it comes to these issues, and then just walk you through some policy highlights on broad strategies that can be used to address various aspects of the system. And then I'll close out by offering up a few action opportunities, because I think every good panel, needs to have some sort of a call to action at the end of it. So just to start off with those framing points, the first transition that I would love to make is that thus far tonight, we have really focused on the injustices of the criminal legal system. What we have not talked about or focused on at all is safety. which is actually ironic given that theoretically this entire system that we are talking about here tonight is our system of public safety. But what I can say with absolute sureness after hearing everybody talk is that there's nothing about this current system that is safe at all. And that if we are going to create actual safety in this country, we are going to need to have a new approach entirely. And that's one of the reasons why I think that the public health community does have such a unique role to play in this conversation. Number one, you can just attest to the fact that all of the practices inside of carceral facilities, as well as the way that people who are formerly incarcerated are treated across society, you can attest to the fact that these systems truly are unsafe. But the second reason is that from public health, we have a deeper lesson about how we should think about these broader, complicated issues, which is that prevention is always going to be our most effective way of solving problems. So when we look at our biggest gains in life expectancy, those have come about because of investments in hygiene, right? In sewers, in air quality. Well, the same is also true of safety. Like if we actually care about keeping people safe in our communities, we should be making sure that there are streetlights. We should be making sure people have access to physical and mental health care. We should be making sure that people have adequate employment opportunities and clean air to breathe. That's the first main message that I wanted to send. The second message I just wanted to send before diving into some of these specifics is that this conversation really is broader than just people in the public health space or people in the criminal legal advocacy space. And that to be successful in making this paradigm shift in how we think about safety, we are going to need cross-movement collaboration. That's number one, because all of our most effective strategies are ultimately going to draw from social policy systems that are spread across society. But it's also because we are here in large part because of these broader decisions that we have made as a country about how we spend our money. And if we don't start to rethink those systems, we're never going to fix these problems by making changes to the criminal legal system. So it is not a coincidence that in the 1980s, we slashed our spending in social policies. We moved ourselves towards systems that were cutting back on healthcare, that were decimating the quality of our schools. And those are also the same years when our jail rate population started to climb in the hockey stick wave that we have had leading up through the present. And so we are going to need people from all different movement spaces to really come together to advocate not only for the sort of policy changes that I'm going to talk about now, but more broadly, just to rebalance our spending priorities so that we are actually investing in people, that we are investing in communities, that we are investing in upfront prevention and supports, and not in cages that are inflicting all of the harms and the atrocities that you've been hearing about tonight. So with that being said, I would just want to give a quick overview of some of the sorts of policies that are just important to have on your radar and that are important to advocate for in whatever ways we can at the local, the state, and the federal levels. So when it comes to policies to address these issues, usually within the criminal legal advocacy space, we think about these policies in three main buckets: prevention, everything that happens during incarceration, and then reentry. And so I'm actually going to move backwards through this process, just to uplift some policies, simply because prevention, tying into what I was saying before, is really the area that I think in particular we can lean into now and really use, I think, more voices from the public health space to really add to that conversation. So when it comes to reentry, the biggest priority is just to dismantle this network of collateral consequences. So in other words, all of these sorts of barriers that we put up for formerly incarcerated or people who have had encounters with the criminal legal system in accessing all of their basic rights as democratic citizens. So that means dismantling the barriers to voting rights. It means making sure that we don't have barriers in place for accessing higher education. It means making sure that people who are formerly incarcerated aren't going to have barriers to getting basic public housing, to getting various forms of public benefits, either at the federal level or at the state level. And it means making sure that we're also not putting up barriers to work, whether that is through discrimination in the private market or whether that is through occupational licensing restrictions that will sometimes foreclose huge industries like being a barber or becoming an architect. Suddenly there are character and fitness requirements that make these occupations completely off limits. So there are lots of policies, number one, just removing some of those barriers, but then also doing things like requiring fair chance hiring policies where criminal records are no longer going to be used as this initial screen in the hiring process. Doing the same thing for housing to make sure that people who are renting out apartments are also not going to be screening out people in early aspects of this process. So those are just some of the policies to uplift when it comes to reentry. Moving backwards now, so in looking at what is happening in jails and prisons, I just want to preface this section by saying that nothing I say is actually going to address the problems you are hearing about, which is why if I could have one message, it is that this current system just can't be fixed, right? That's not, I think, what any of us here are saying. I mean, we need a system that doesn't use these institutions as how we keep people safe. So with that being said, there are certainly things that we can do now that will absolutely improve the lives of all of the people who are currently sitting in cages. So one of those is just really attacking head on some of the lack of dignity that Jorge and also that Allison were talking about when they were giving their presentations earlier. So there are bills at the federal level, like the Dignity for Incarcerated Women Act, that would be addressing some of the inhumane conditions. This one in particular for women having to deal with access to sanitary products, also making sure that they are going to be incarcerated, that if they're going to be incarcerated, it will be closer to their families. So making sure that there's more access to trauma-informed care. So this has been a major priority for some of the major organizations that are working to support incarcerated women. Another major reform is having to do with some of the employment issues that Jorge was getting at. So we could certainly try to just simply repeal the exception clause in the 13th Amendment. We can also, if that is too hard a bar right now, pass requirements that anybody who is working in a carceral facility has to be paid the prevailing wage compared to their surroundings. So as one way just to get at this prison economy that we currently have that is propping so much of this system up. But one other thing that we can also do dealing with the finances within carceral facilities is to get rid of all of the fees and fines that we heap on people while they're locked up, and which also makes re-entry so much harder on the back end. Right now on average, or at least as of the last report on this, people were exiting incarceration with an average debt of $13,500. And that's compared to some of the figures you were hearing about people whose median income is less than $10,000. So that means making sure that you don't have to pay for things like sanitary products. It means making sure that you don't have medical copays, which is even more important during pandemics and other sorts of public health emergencies. And just generally speaking, making sure that we are not making people incarcerated pay for the entire costs of what they're experiencing. And then just the final thing to uplift in this bucket is to make sure that we make it easier for people to bring lawsuits to actually challenge the inhumane conditions they're facing. So in particular, repealing the Prison Litigation Reform Act is a pretty high priority of a lot of groups like mine that would just love to have more ways to challenge this inhumanity. So then the final category is moving to prevention. And so in this bucket, there are certain policies we can look at that would prevent people from entering into the system. So things like bail reform, make sure that the money in someone's pocketbook is never going to determine whether or not they have to spend a year or 2 years locked up pre-trial. But it also means investing in alternative ways of actually resolving crises and making sure that people never contact the criminal legal system. So just a few examples of this. There is a piece of legislation called the People's Response Act that would be really starting to engender some of this paradigm shift. So what it would do is set up a division of community safety at the Department of Health and Human Services in Washington, D.C. And then it would use this new division to make purely non-carceral, so outside of the criminal legal system, grants to community-based organizations, to state governments, and to local governments all across the country, so that they can really be investing in the social determinants of safety, so that they can then be putting money into streetlights and into mental health and into physical health, into harm reduction-based treatment, into restorative justice, into all of these other sorts of approaches, into non-carceral crisis response, violence interruption. Like, we have evidence to know what are the things that really keep people safe. What we don't have are the structures to make those investments and to make them with the same level of of strength, really, that we are currently putting our resources into the criminal legal system, right? So like, what if we were actually spending our money instead on all the things I just mentioned a moment ago, instead of building new jails? So that's just, one example, but at a high level, the final point I would make on prevention is that, again, I would say that almost any social policy you can think of at the end of the day, I would put into this prevention bucket, because ultimately what our goal should be is to take the money that we are currently using to finance this carceral state, and instead to be having that spread across all of the sorts of investments that when you talk to people on the ground, they're going to uplift as being the ingredients not only for safety, but for quality of life, for happiness, and just for having the kind of resilient communities that I think we all want to have. So that's all I have to say, and would just note that we have some action opportunities. If you're interested in anything you heard, you are welcome to join our community safety listserv in order to just get more action alerts moving forward, or new resources on these issues. We have a link to sign up for a public health sign-on letter for the People's Response Act. If you're excited by that concept, we would love more signers on that. And then in terms of the policies related to reentry and during incarceration, there is a platform called Vision for Justice, which has about probably 400 different policies packed in there, spread across 18 different issue areas. And so I was able to give, just a couple of policies here tonight, but there are many, many more, and we're happy to pass along that resource, and then also ways to plug into that Vision for Justice community.
Thank you so much. And we'll get anyone that signed up for the webinar tonight, we'll send them all the resources. So with that, we'll move on to the Q&A portion. Thank you, Thea. I'll start us off, and then feel free to put some questions in the chat. We already have a few. This is a question for everyone, and I kind of wanted to ask this question just because we have so many different perspectives here on the panel, and I think everyone will kind of approach it from a different perspective. I've heard this, a lot of you touched on this. What are some ways, and I think another simple thing that I've learned just over the past few years in this space is the importance of language and how we talk about people who are incarcerated, how we talk about even using the phrase criminal justice system is loaded. So I just want each of you just to kind of touch on how you view kind of the power of language and how we talk about people who are incarcerated in these systems and ways you've changed over the past few years. So I'll just kind of throw it up to the group, whoever wants to take it first.
I guess I'll take it first. So I was an obstetrical nurse, and within my practice, and this is before I went into harm reduction and research and things like that, but there were some terms that, I wasn't even aware of that perpetuated stigma, right? And some terms, I knew that, it wasn't really mindful, and others I completely overlooked. But, it wasn't until, I really started, collaborating with community stakeholders and with populations and informing myself in harm reduction, that I learned that, language, just like what you had mentioned, criminal justice system, we use that because that's sort of like a term that's thrown around a lot, but being leaders and advocates and allies of people with histories of arrest, it's best to use terms like institutions of incarceration, instead of criminal, right? Because the word criminal perpetuates punitive mindsets. And reproductive health care, I don't know if anybody's heard this term, you may have, but the term crack baby, that reinforces, or drug baby, right? That reinforces punitive mindsets around infants that are born to individuals maybe with substance use disorder or exposure to substances in utero. And so language like that, just perpetuates, punitive mindsets and also mentalities that, those children or infants don't deserve the same quality of care as others. And so I saw that in practice a lot, where that language was thrown around. Also language that is binary or, non-inclusive in that nature. So just being mindful, regardless of what population you serve, not making assumptions around gender, for instance, or gender identity, that could really perpetuate trauma. So we learned that a lot of people that are influenced by arrest either come from trauma or are experiencing trauma during that time, during arrest or after. So not perpetuating that trauma. So I try to use non-binary language such as individuals, that identify as women, or a lot of the literature now is trying to get us to go away from binary terms, such as instead of using the terms breastfeeding, using things like chest feeding, just being more mindful about other people's identities and experiences. I'll pass it to somebody else now.
Yeah, if I can say just a couple of quick things here. I applaud you for those stances and for those changes. Criminal justice is something that we, as the director of the division here at Latino Justice, we're trying to get away from. And we kind of moved to criminal legal, but again, that's kind of a misnomer also. And then my title is director, National Criminal Justice Director. Well, do I take out the justice, which is amorphous, and do I leave the criminal, which is kind of cuts close to home? What do I say? Director of prisons, and do I want to say the guy who's going to be in charge, hopefully, of getting rid of all prisons, which is what I want to do in the first place? I don't know. As someone who spent as much time as I did, and as a Latino male in this country, I'm kind of thick-skinned. So to be honest, the terms that are maybe people trying to do away with in order to inflict more pain or trauma on me or whatever that I might feel or whatever are not the ones that I'm most interested in. I'm most interested in, as a poet and as a writer, the ones that make you stop and think about what the hell we're doing. So, which is why I like to use cage, because where these people are is they are in cages. I try to use cells. I don't like using dormitories. I don't like using living areas. I don't like using places that will soften the impact of what it is that we're actually doing with our incarceration policies in this country, right? I understand the trauma that is inflicted on individuals who have been dehumanized all of their life, and I applaud our attempts to move away from that. But I also think that we have to find a way to get to the policymakers, the public, to have them become aware, to have them squirm. I want to see them squirm, and I want to say, but wait, cages are what we do to animals. And I want to say, yeah, right, yeah.
Dr. Reinhardt, you as an anthropologist, you think of language quite a bit and how people, talk about themselves and communities talk about themselves. Do you have any comments?
Yeah. Well, my work for a decade has really been focused on self-writing practices. What does it mean when language is never our own? We inherit languages. We don't invent the languages through which we speak, through which we write, through which we're called. So how do people subvert the inheritance of language and try to find ways to make their own worlds, to refuse the violence that they've inherited? So I do think about language a lot. And I also think about when I've been in Cook County Jail, or when I work with people on the South and West Sides who have been incarcerated, who have been subjected to various forms of abuse. What's their primary concern? It's not language. It's the material conditions of their everyday life. And I think if you pass through kind of activist circles, often language becomes a point of fixation. And I think it's very important. I think language has massive consequences. I mean, this is my investment as a writer, as a thinker. I think about language as a psychoanalyst. I think about language all the time. I think it also can become an obstacle to effective solidarity when this becomes a kind of site of contentious fixation rather than kind of a collaborative vehicle through which we try to alter the frameworks through which we're working. So I'm all for example, what Allison was describing, and I do try to use these kinds of languages. There's sometimes where editors push for a language that I wouldn't use myself, but if the question is get this piece published or just keep fighting about these terms, I get the piece published. And I accept the terms, I compromise. So I think language is it's inherently a site of compromise. No language is adequate to what we're trying to describe. No language is adequate to the richness of any person we might use to describe it with. And then I think maybe language is inherently a practice of harm reduction. in the fact that language is always reductive. How do you work with it effectively to produce the changes that you're after in the world that are dictated to you by the people who are most affected by the violences we're confronting? So I think language is important. I think it's important we also not, as kind of activists or privileged community of physicians or whoever else, let this be kind of the be all end all of our work, and keep in mind what are the concrete material changes we're trying to affect.
Yeah, and maybe I'll just add on 2 quick points. So the first one is just, without getting into specific words or phrases, the question I would just always ask myself is this phrasing, is this word treating people with dignity and humanity? And I just feel like if the answer is yes, use the word, right? If the answer is no, think pretty carefully about it. I think then the second point is just where I think about language more is getting a bit in, I think, to what Eric was saying, which is that language is strategic. So when you are involved in policy conversations, you're oftentimes trying to convince people who don't agree with you to do things that they really don't want to do. And so what's important is to think about how to convey that idea in a way that is going to resonate with them. And the way that I oftentimes will try to approach that on these sorts of issues is I actually take a very values-based frame. And I start off with this basic premise that you care about safety, I care about safety. We're basically the same. We want to walk home at night and not be scared. Me too. I want to be able to have kids who can go to school and not worry about getting bullied or all those things. We're really the same. Now, let me tell you why my policies are the best way to get us both to that end goal. But I try to adopt a values-based affirmative narrative structure. So again, not specific words, but those are kind of my 2 benchmarks that I use when thinking about language choice.
We had a question for Jorge. What kind of actions would you like to see come out of discussions like this? And then, anyone else can answer that as well.
Jorge, I think you're muted.
Yeah, I'm sorry. I almost read a poem called Unmute Yourself. That's true, it's a true story. No one really talked about much about the psychological impacts of prison. I've had a couple of assessments done, never formal assessments on PTSD, and in both instances the therapist said, "Oh, you must have PTSD. You spent 27 years in prison." Yeah, okay, well, but there was never an assessment done, and there was never a how does it relate to how I walk through life? We've talked a lot about narrative, about using individuals' narratives in order to change policy, right? I agree with you on that totally. It's one of the bedrocks of how we move policy in most of the arenas that I've been in. I also did something once called Nourishing My Nightmares, which has to do with the fact that in order for me to tell a narrative and to have it authentic and to have it move you, it has to be real and it has to be personal. And for me to do that, I have to be in touch with that, which means that I cannot totally heal from whatever it was that caused that damn trauma in the first place, which means that I have to be able to access that on a regular basis. And when the day I get rid of it, I'm just telling you a rote story. I'm not connecting with you. For me to connect with you, I have to be able to access that in a way that's real and personal. And that what that's going to do likely is the next 2 days I'm going to have nightmares. So, but people don't have access to therapy. I have had professional therapists come up to me and suggested maybe every damn psychologist, LMSW, LCSW, whatever it is, anyone that goes into that sort of field should do pro bono hours in the local jail, county, prison, whatever, in order to give individuals who are coming out of prison some sort of way to access whatever has been done to their psyche and their spirit and their emotions and whatever, and not just their willingness to lash out. I would really like to see some change come about in how we offer not just housing and employment and the stuff that comes to reentry with people who live in cages, but how do they address goddamn damage that we've done to their souls, right? Yeah.
Could I be kind of, I feel like it's absurd to even think of adding to what Jorge just said, but it really provoked me in some kind of way. I think there's a very famous anti-colonialist psychiatrist, Frantz Fanon. And Frantz Fanon was a big proponent of day hospitalization programs. He's dealing with people who are dealing with the trauma of being tortured by French colonists, for example, in Algeria. And he's thinking about how do we produce a radical form of treatment that isn't simply about basically assuaging the harms that have been done to people, but producing a platform for real change. And he thinks that it's not through putting people in asylums, locking them up, as we do now in jails, for example, that we do this, but it's through the work of day hospitalization, where people come, they work in communities, they work in treatment paradigms, etc., and they go back home and they go to their communities and they're constantly living in the milieu, in the environment that has inflicted violence on them, so that they can also engage with it. It's only in that there's the possibility of working through. This is both as a form of like working through as a kind of catchphrase for psychoanalysis, remembering, repeating, working through is an important essay by Freud, for example. But when you deal with trauma, if you just try to medicate it away, as we do on psychiatric wards that I work on all the time, and subdue symptoms, that is not a radical paradigm. That is not a revolutionary paradigm. That's not a paradigm for change. That's a paradigm for kind of obscuring what is happening. And I think this is very important. Psychopharmaceuticals are very important for mitigating suffering, for making life livable for people. But I think what you're describing, Jorge, this like nourishing your nightmares, I think really resonates with Fanon was after, which is only through a constant everyday engagement with the things that have been done to us, with the things we do to other people as a society, that we can begin to generate the kinds of solidarities, the kinds of communities, the kinds of action to change them, not simply bury them. So I really appreciated what you said, Jorge. It resonated very much with me.
Thank you to both of them. We had a great question. How do profit incentives, in privatized health insurance industries and jails and prisons perpetuate the inequities that we heard about tonight? I think all of you could speak on this in different ways.
I'm happy to kick off that conversation. So all the ways is the short answer. One point that we should definitely make is that some of the kind of anecdotes and specific examples I can give now will focus on privatized facilities, but that these incentives actually exist for public institutions as well. And we sometimes lose sight of that. I think Jorge was sort of referencing this before, but we just can't blame privatization for everything. We have to look deeper. This is the system itself. So do want to say that, but just to give you, a few quick examples. So the organization where I work, Civil Rights Corps, has an impact litigation side of the house, which brings cases which in large part actually do challenge these sorts of incentives and oftentimes take on private like probation companies and other sorts of private actors that are profiting off of the criminal legal system. So one good example is that we had a case that was suing some private probation companies that were actually just debt collectors. So they didn't do anything except for charge the people who were using their service every single month and then just shovel that money into their pockets. So we ended up, suing these companies. We challenged their practices as being unconstitutional, and we were ultimately able to, win that case by settling with them. But that's, one kind of big place where you have these different companies that, again, are using these like user fees and using those fees then just to enrich themselves because they can charge almost as much as they want and expend very, very little because they provide next to no services. Just one more example to kind of throw out there is that there's some very famous examples of how various sorts of facilities, oftentimes privatized ones, will get paid per night per person that they have actually in their facility bed. And the thing is, because they're really getting paid every time someone comes in, let's say that somebody is released from their institution, gone for 2 months and comes back, well, now they get paid again. So in other words, they have no incentive to provide any sort of reentry support. In fact, they have every incentive to make sure that people are coming back and coming back and coming back. And, that's one of the reasons why, unfortunately, I feel like the criminal legal system is like the opposite of Field of Dreams, or I should say it is Field of Dreams, but like in a nightmare world. Like, build it, people really will come. You build a new jail, and guess what? That local system will find a way to fill the jail. You build a new prison, people will find a way to fill that prison, whatever it takes. And so that's just, one thing at a higher level about these incentives is like every time you set up a new structure, you are now incentivizing all of the actors around that to find ways to make good use of it.
So one question I have, and this is, we could spend the entire night on this. So we talk about how terrible healthcare is in the jail, and how deplorable the conditions are. And then we also talk about, reimagining the entire carceral system to, community-based, restorative justice. So how do we balance spending resources on fixing immediate problems and then with goals of kind of reimagining and restarting the entire system? I come from a global health background, and that was a huge discussion. And this is kind of one that I have is, how do we balance that? How do we fix the terrible things that happen now, the immediate problems, but then also how do we, because you can get stuck doing one and not the other, or dreaming of one and not focusing on the present issue. So I'd just like to hear you all discuss that.
Maybe I'll go first, just so I can say my ambitious stupidity and other people can tell me to think more reasonably. But I think the idea of separating kind of a response to the immediate present and the grand visions that we have, it makes sense. I understand why, especially like in global health paradigms, for example, that would be an important distinction to make. I think it's also something we should refuse. These are one and the same. Building the systems that we need is confluent with responding to the emergency that we have in front of us right now. So, Taya, for example, was elaborating, I think you said 400 policies that you have on this website. I need to look through them, and I would learn a lot from them, so I want to look through them. But I think, if we're talking to the US public, or we're talking to people in Texas right now, we're not going to go through 400 policies and be able to make an impact in the way that we need to in terms of popular consciousness and awareness of these systems and political platforms to shift things in a dramatic way. We need a kind of consolidation of these around an ambitious project for change now. We had, for example, it failed, but we had a bold, ambitious project for infrastructure investments in the US that Biden came into office proposing. And I mean, it failed in the sense that it was reduced to like a quarter of the size that was proposed and is not nearly adequate for the problems that we face in terms of infrastructure in the US. But, you also have like grand visions for a Green New Deal. Has it happened yet? No. But you have a lot of movement that you wouldn't have anticipated 10 years ago. People, kind of shooed AOC and others off the stage when they're, proposing these kinds of things. But it's gained traction. We need that kind of an ambitious paradigm for decarceration, I think. Something akin to a national decarceration program, like a national infrastructure investment or like Green New Deal. And that part of that will be bringing up what is the current system. A lot of people in the US, most people in the US, including our policymakers, do not understand the incredible violence that's perpetrated every single day in our carceral systems. And when we talk about health, there's a constitutional right, a legal right to proper health care inside US carceral systems, and there's no system to enforce that. There's a voluntary accreditation system for the quality of healthcare that very few institutions actually subscribe to. It's voluntary, it has no teeth whatsoever. So that now there's a randomized controlled trial being done by Crystal Yang at Harvard Law School to look at what does it do if people actually subscribe to just accreditation programs for healthcare quality inside jails. The idea that that could even be a possible RCT is absurd. How is it that you have a constitutional right and no system to enforce it? So these kinds of basic gaps in our system need to be brought into popular consciousness, I think, in conjunction with a reparative project that's ambitious, that stimulates kind of popular enthusiasm that people are asked every time they are running for Senate or or the House or presidency, whatever. Like, what is your position on the national decarceration program? We don't have that kind of a discursive paradigm. I think it's really important we do that. This is, I guess I got a little bit away from your question, Mark, but I think to bring that together, that kind of ambition with the immediate response, the immediate crisis that we have, is the challenge that we need to face, because it's part of galvanizing popular consciousness around the emergency that is transpiring every single day, and linking that to a grand vision for a policy project that would address that we need and we don't have. People are aware of how horrible, some people are aware of how horrible things are in jails and prisons. You know, it's just a horrible tragedy. There isn't a popular consciousness of what it is we can do about it in terms of a single paradigm that we can all hearken to and you know, rally around. And I think we need that kind of a unified agenda as a community to build the solidarities we need.
I can go if no one else wants to, but Jorge or Allison, do you want to go?
I could just add that within my sample and the people that I work with, a lot that was brought up was poverty. And so many times they said, I wouldn't be in this situation, and a lot of the violence inflicted on me, I wouldn't have experienced had I not been in poverty, right? And so poverty a lot of times perpetuated instances where they had to do things, just like one of the quotes that a lot of my participants echoed, they just had to do whatever they or the institutions wanted them to do, right? And so a lot of times they were forced into sex work, coerced into sex work a lot of times. And this was something that was really interesting. And I didn't know this. A lot of them were forced or chose sex work because it was a lesser charge than petty theft. And so, you know, when we talk about some of the health disparities, oftentimes stigmatized health disparities, such as, you know, different sexual related diseases, you know, unintended pregnancies, and then sexual violence. A lot of times, you know, our systems perpetuate that thing, you know, those things. And a lot of times us as clinicians perpetuate people that experience those health disparities not to seek care because we don't really understand the context of them. But I just want everybody to know that a lot of times people that often go into that lifestyle or that or who have histories of that often are forced into that because of poverty. So I think the big thing there is poverty, and universal access to healthcare, I think would really assist with some of these things that we've talked about this evening.
If I can, I found myself, yeah, I agree with you. You know, some of the legislation that's coming down the pipe, some of the people that you're talking about, I agree with, right? Totally. That would address a lot of stuff that we're talking about. But you know, there's only so much stuff we can legislate. You know, it's even among committed activists. A lot of times, what I hear is, I'll hear this. This individual was pushed into doing what they did because they were poor. And I'm not at all referring to what Dr. Parker was talking about, but I'm talking about other arguments about why we should maybe not give someone this harsh of a sentence, or they did something because they were under the influence of drugs, or they did this, whatever. And they're using that as a way to kind of excuse the harsher crimes. And we're always able to make justifications for whatever a crime that was not one of violence, or one that we just had with possession, or one that had to do with robbing property or whatever. But until we can get to the point where we can actually look at the individual at the end of the run, who is peeing on themselves and writing on the wall with their own excrement, and see that they also are not disposable, and that they also are the ones who are deserving our compassion and our love and our care, then I think, and if we can get to that as a society, and I don't know how we're going to do that, then I don't know how much legislation we're going to move, because we're always going to have exceptions. We're always going to write exceptions for this individual, for that group, for that politician, for this interest group, or do whatever. And we're never going to extend it to everybody. And And until we're willing to do that and go on the record as individuals, as organizations, to say that I believe in the sanctity of everyone, that I believe that no individual is disposable, despite what they've done, and I'm not going to go for this, and we push that envelope because we're a country that's suffering from a lack of imagination when it comes to what we do with individuals who have offended us, right? Someone steals our bike, we call the cops. Someone kills our wife, we call the cop. We have the same damn reaction to whatever it is that something bothers us, and we have the same damn response, which is convict, which is arrest, accuse, convict, and incarcerate. We have the same responses for everything. We suffer from a lack of imagination and we don't care. Having said that, a very quick something to the last question, I want to say that I want people to understand that the primary goal behind everything that is done in a carceral institution is done in the name of safety and security of the institution and the staff. Everything. They do not care about the individual who's coming in there, who is cutting herself, who is killing others, who is doing all this stuff, that would be dying from TB. They do not give a damn other than what impact that would have on the safety and security of the institution. That's just the truth. We don't live in Norway, we don't live in Finland, we don't live in countries that actually see people who are being brought in there as humans, or somebody be and of course I'm painting with a broad brush here. There are wardens walking Texas who treat people with dignity and compassion. But by and large, the people running our prison institutions, our penal institutions, the people who are doing them squad cars, people who are doing all that stuff, do not see individuals worthy of compassion and care and love. They don't do that. That's what impact is that going to have on me, on those close to me, and on my institution. And that's what drives every damn thing that they do. So Eric, I'm down with you and I'm ready to push for that. And Thea, yes, I'm on board with all that. In fact, we did some stuff last year. We did some panels around, trying to support that. But yeah, I mean, I'm cynical.
I'll maybe just quickly add just two things. Just Mark, I do want to go back to kind of how you balance the need for this short-term kind of stopping the pain that people are currently experiencing, balancing that against these broader systemic reforms. And just quickly, one thing I would say that I always found useful is just this idea that when you're looking at a policy change that's possible, you ask yourself whether, if you pass this, is it going to make it harder or easier to get the bigger, bolder changes you need in the future? It's pretty simple, right? This is kind of the critical resistance framework. I did not coin this concept, but I think that it is a really helpful lens, because sometimes, for example, like building that massive new facility, that may make it a lot harder for the reasons we are talking about to get to the future you want. But something that is, closing down some sort of a segregated unit, right? That's not going to make it harder, right? So just thinking through every reform through that lens is just one thing. And then I would just say, on the bigger, bolder point, so I did pass along kind of the Breathe Act, and I think the Breathe Act is, this massive legislative proposal from the Movement for Black Lives, which is trying to be, I think, Eric, some of what you're talking about. And the People's Response Act actually is Section 2 of the Breathe Act. So it all kind of fits together. And the People's Response Act was the first bill directly modeled on the Breathe Act. But, I'd also just spotlight that this work isn't just happening at the federal level. So in fact, I don't think there's enough time, but I could put Krish and Gabriella from Texas Jail Project on here to talk about the Community Safety Agenda project taking place right now in Harris County, which I think is one great model for, how you can create this policy agenda of really kind of disparate solutions like housing and health, et cetera, but unite that all through a safety frame. And then, we can make that something that candidates run on. And we ask them, do you support the community safety agenda? They say yes or no. And if they say no, we make that a problem, right? So I agree with you. I think that's exactly where we need to go, and love to work with everyone on this call to get us there.
Yeah, thank you. Yeah, I didn't mean to suggest that this idea of like a national incarceration program doesn't exist, but it doesn't exist in popular discourse in the way that we need it to. And how do we get it there so that every candidate is held accountable to it, so that everybody in the US knows about it? Like, it would be hard, I think probably 70-80% of Americans have heard of the Green New Deal. Maybe they don't know exactly what it is, but they've heard of it. How many Americans have heard of something like the Breathe Act or the National Incarceration Program? Almost none, and unless there is accountability to an idea that exists in the popular register, I think we don't make progress. And I think in order to get things in the popular register, they have to be bold, they have to be ambitious, they have to grab attention. You know, you can criticize, for example, and there may be appropriate criticisms of defund the police as a slogan, but by God, it sure got something into popular consciousness that really hadn't been there before. And that's a major political move. If you don't do that, you don't have a starting point. And for a lot of our decarceral work, we still lack that kind of starting point within public discourse. I think we need a lot of kind of provocative work to get to that point.
Well, I want to be respectful of everyone's time. Does anyone have any final thoughts or comments that they want to make? Really, this is amazing. Y'all have given me so much life. And this was just absolutely wonderful. So it's just absolutely a pleasure for me. I don't care what anyone else thinks, but this has just been wonderful. So like I said, this is the starting point. This is the beginning. There's so much work that needs to be done. And I think we can find a lot of people to do it. And so I really thank you all for taking the time tonight. Thank you everyone for joining us here and on Facebook Live. And I hope to see you all again in the near future. All right, we'll send documents and everything to everyone who signed on. So panelists, if there's anything you want us to send out, please send it to me or Ariana. Thank you all very much.
Thank you, Mark. Bye.